Hello, and welcome to session 4. We're going to be moving from London over to Leipzig, Germany, where we'll be watching an ablation of an atrial tachycardia, I believe. The case will be performed by Arash Arya from the Leipzig Heart Institute. And allow me to quickly introduce the panel that'll be watching this case with us. First, we have Professor Carina Blomström-Lundqvist from Uppsala, Sweden. We have Boris Schmidt from Frankfurt, Germany, and Claire Martin from the Royal Papworth in the UK. Thanks, folks. Thanks for joining us. Are we ready to go live to Leipzig?
Hello and welcome to Leipzig. First, before I introduce the team, I have to say that because of a small accident that you can see, what happened to me, I was not able to do the ablation today. So first I asked my dear colleague, Dr. Angeliki Dharma, to perform this ablation for you. And now I start to introduce the team. Dr. Angeliki Dharma, one of the best electrophysiologists here in Leipzig, will perform the catheter ablation. We have, I would like also to introduce our nurses, Nastasia and Ramona, who will perform the sedation and also control the situation of the patient. And last but not least, what is very important, to have a very good technical support. Then today is my privilege to have Dominic for technical support to perform this ablation procedure, and this is my honor to present this case for you. So, as you said, this is a patient, a catheter ablation of atrial fibrillation after previous PV isolation. The patient is a 75-year-old man with persistent atrial fibrillation who had in 2011 the first PV isolation. At that time, the voltage map was completely normal. The patient received PV isolation, and after that, the patient was completely asymptomatic. From the risk factors, he has hypertension, hyperlipidemia, mild aortic stenosis, moderate stenosis in the left circumflex artery. For the first time, 7 years after catheter ablation, in 2018, the patient experienced AF recurrence. And at that time, he received amiodarone, and he was completely asymptomatic until April 2020. And he experienced recurrent atrial tachycardia despite antiarrhythmic therapy. So we discussed all the options with him, and we decided to do the catheter ablation. In the next slide, you can see the left atrium, three-dimensional reconstruction of the left atrium in MRI. And as we can see here, the pulmonary vein region is small in comparison to the rest of the left atrium. The left atrium is large. So this is a summary of our patient, and now I would like to wait for your feedback, and then we can discuss how we approach to this procedure.
I don't know if you can hear me now, Arash.
Yes, right now I can hear you, yes.
Okay, great, thanks.
Okay.
Yeah, very interesting case. I mean, 7 years of sinus rhythm after a pure pulmonary vein isolation procedure at the age of 68. That's a great success,
Yes.
I think. And
Yes.
now he obviously has an enlarged left atrium. Did you also look for
Yes.
low voltage or let's say late enhancement in the MRI? Are you like checking this on a regular basis or?
No, unfortunately, on a regular basis, we don't check for late gadolinium enhancement in atrium. But the only thing that I can say, we had already did a voltage map for him. Then we can later we can see the map together. That at that time during the first ablation, he had no low voltage area, but now we can see some low voltage area in the left atrium.
Interesting.
Yes. So I think first we can look at the ECG of the patient. If we are able to see the EP system, so we can see the ECG of the patient, we can see the atrial tachycardia, and it is very interesting to see that we have no isoelectric line between the P waves, so it suggests that it most probably is a macro-reentrant atrial tachycardia, and when we look, we see that at the first look, it looks like a typical atrial flutter, but when we put the CS catheter inside, we saw that the CS12 or distal CS is earlier than the proximal CS, and also the P-wave morphology is more compatible with the left atrial tachycardia. And so at this point, if you agree, I would like to ask Dr. Dharma to tell about the procedure, how we approach the procedure, the punctures, and because earlier we used to perform double transeptal puncture, and we have transeptal puncture for ablation catheter, transeptal puncture for lasso catheter, and also CS and RV catheter, but especially after high power short duration ablation and the high incidence of first pass pulmonary vein isolation, and also having in mind that in the future with a high power short duration, we would be able to do the same day discharge pulmonary vein ablation. We try to reduce the number of our punctures to hopefully to do same day discharge procedures in the near future. So please, Angeliki.
So we performed 2 punctures in the femoral vein. We have a 7 French and an 11 French sheath. Through the 7 French sheath, we have the CS catheter, and through the 11 French sheath, we have the Agilis. If you can see, we have already performed the transeptal punction. We want to try it. And we have already performed an activation mapping of the left atrium. Dominic, could you please show the other side?
Can we have the NAVAX or mapping system? Yes, now we can see the map. Okay.
Okay.
Okay, now I think they have it. Yes.
Perfect. As you can see, we have, I think, 13,000 points. And we have performed a very detailed map of the whole left atrium. Dominic, can you turn it around? And play the propagation map, please. Exactly. So it seems like we have a perimitral flutter. And we had like some very interesting signals with had a grid on the septal wall of the atrium. If you can show an RAO, please. Exactly here. Could we show?
Can we add also the EP image? Yeah, yes, the
Exactly.
EP system, so we can also see online the signals that we see during mapping, and also in the mapping system. Actually, I have to say we would. At the first, we wanted to present this case using the EnSight X to show the difference between conventional mapping using NAVAX precision and the differences that this system has with the new EnSight X. Unfortunately, we were not able to perform this procedure with the EnSight X system, so we decided to go back to the NAVAX precision to performing this ablation. As you see, we just performed 2 punctures, one of them for the CS catheter and the other one for first to use the HD grid to have a high resolution mapping to see the activation map. At this time, we didn't do the entrainment mapping because we thought that maybe during entrainment we may change the tachycardia. So first we wanted to see the tachycardia together before doing any kind of entrainment mapping. So after activation map, then as you saw, we had this propagation map, which is most compatible with the perimitral atrial tachycardia, macro-reentrant atrial tachycardia. And Dominic, we can see, is it possible also to see? Yes.
That's a fantastic map. It really covers the whole cycle length of the tachycardia, obviously.
Yes.
Are you able to show us the isochronals of that map to display the zone of slow conduction?
Yes, we
or
try
does
to.
it even matter to you to see that?
Yes, I will try to ask Dominic to do that. He cannot hear you, so I will go and tell him to do that.
And while he's asking, so I did not really understand the advantage of doing just one transeptal puncture. So number one, you now have to exchange the HD grid for an ablation catheter. Second, how do you check whether your line is really blocked if you have only one catheter in the left atrium? And
yes, of course.
Well, usually a second transeptal is not that much of a deal.
No, you're right. Actually, the reason why we reduced the number of our puncture, as I said, until several months ago, we had, or more than 1 year actually, it's almost 12 to 18 months. We did almost always double transeptal puncture. And then I think, yes, you are right, we have to change the catheter. For example, maybe we need to change the ablation catheter with HD grid, especially with live view, to say, okay, do we have a complete block or the line of block is still not complete? This method had disadvantage that we have to change the catheter. From the other hand, we do less puncture, and as I said, we are looking forward to reach a point to minimize the number of punctures to go for the same-day discharge pulmonary vein ablation in an ambulatory and an outpatient basis. That was the main reason. The second reason was that we saw that with high-power, short-duration ablation, the ablation is much more effective and faster, and actually the number of cases that we are able to do the first pass isolation is real more than 90%. So I think the advantage of having a lasso catheter or HD grid catheter plus ablation catheter is not that high compared to the ablation procedure that we used to do 2 or 3 years ago. In addition, for some catheters, for example, you saw an example of the mini electrodes on the Q-dot catheter yesterday, that even during ablation, we can see very easily and the signal, even during ablation on these microelectrodes, and then we can see how the signal, we see the delay, and also as the signal is completely go away, so we can say, okay, this region is ablated successfully. So I don't say that we have to discard 2 transeptal punctures everywhere. I just wanted to show our routine procedure here. And I think this has some advantages for us. It makes the procedure faster. We have less puncture, and because we have less puncture, even we use ultrasound guided puncture. I think with less puncture we will be able to decrease the number of vascular complication. And when we compared the number of our vascular complication in 2020 and we compare it with 2019, we see a significant decrease in the number of vascular complication. And putting all together, that was the reason that in most of the cases, or actually almost all of them, we discard the second transeptal puncture, and then we do 1 transeptal puncture, having in mind, as you said, yes, it's correct, we need to change catheters 2-3 times during the procedure to check for the PV isolation and also to check if our ablation line is complete.
Do you find it difficult at all, for example, if you don't have 2 catheters in the left side, you can't, for example, put 1 catheter in the base of the appendage and pace there? If you're trying to look for block across a line, does that limit you in only being able to pace from the right side of the heart?
Yes, you are right. When we have just 1 catheter, it's very difficult to, for example, to stimulate from left atrial appendage and then look at the ablation line. So we can compensate this, for example, with ablation distal in the coronary sinus. This is one of the possibilities. And in addition, we can also use, again, for example, in this case, the HD grid catheter to do the activation map. I think still we have good possibilities to check for isolation of the line and also check for the isolation, for example, of the posterior wall in the box lesion. We can do it still with just 1 catheter in the left atrium and 1 in the coronary sinus.
Yeah, I agree. That's what we are doing in our hospital as well, only using 1 transeptal, and you can pace from the coronary sinus distal and proximal and even sort of push the coronary sinus catheter further in if you have a thin tip.
Yes.
So was the patient in tachycardia when he was admitted, when he arrived to your lab, or?
Yes, actually, today because in the history of the patient, always in his file, it was written that the patient has atrial fibrillation. And then when we saw together today the ECG, and Angeliki told me it looks like an atrial tachycardia, and I said, yeah, it's interesting. Atrial tachycardia is always interesting to look at the ECG, to have the map. And of course, even if we ablate the atrial tachycardia, it's not the end of the procedure, because having in mind that he has a very late recurrence. And we know that there are some risk factors for very late recurrence. He's old, and this is one of the one of the risk factors. We also have keep in mind that the patients with very late recurrence like this, they have extra PV triggers more frequently compared to those with earlier recurrence. So actually, I thought that we will check for the pulmonary veins, if the pulmonary veins are isolated, and then look for the extra PV triggers, or maybe voltage map. Or at this point, we can also discuss some, maybe in some degree at least, controversial approach, for example, to empiric isolation of the posterior wall, and so on. But as we saw that this patient has actually atrial tachycardia, we decided, okay, as the first step, We will first map the atrial tachycardia, then we will try to ablate the atrial tachycardia. And after that, the second step would be to check the PV isolation to see if the pulmonary veins are isolated. And if the pulmonary veins are isolated, then we will look usually at our lab at substrate. If there is substrate, then we will do some substrate-guided ablation. I know that there are some controversial data regarding substrate-guided ablation, but at least the study that we performed here, the randomized study here, showed that in our setting, a substrate-guided ablation has a better outcome compared to a standard ablation procedure. And I think this is one of the most important points in catheter ablation of second or third catheter ablation. And the current ongoing studies, especially the PLIA study, will define the appropriate approach to patients with recurrent AF and especially very late recurrence of atrial fibrillation.
So tell me, the previous procedures, was that only PVI or was it associated
Yes.
with some substrate modification?
No. The last procedure showed no low voltage area, and the operator, actually, I did the ablation in 2011, and I did only PV isolation. It was just accidentally today to find out that I did the ablation in 2011, and at that time I did only PV isolation. I looked at the maps and the report of the ablation at that time. It was just a pulmonary vein isolation. But I think during the last several years, he had something, uncontrolled hypertension, I have to say. And then in addition, at that time, he has no aortic stenosis, and now he has mild aortic stenosis, also coronary artery disease. He's older, the left atrium is larger. So this is a dynamic process, and now we have an atrial tachycardia, perimitral atrial tachycardia. At least the ECG and the map looks like a perimitral atrial tachycardia, I think. And then we can also look at the substrate map. Maybe that would be also interesting to look at the substrate map, but it's actually not during sinus rhythm, it was during tachycardia. So now we will go to the substrate map, and we can see that on the septum we have some low voltage area, and if we go back to the posterior wall, actually no large low voltage area in the posterior wall. But of course, we have to remember that it's not actually alone the voltage, but the fragmentation of the signal, and the quality of the signal is also very important. And I think that would be exactly, for example, when you look at the signal in our EP system right now, it might be the amplitude may be normal, but the quality of the signal is fragmented, and sometimes we have fragmented or double potential. And I think this is one of the fields that we need some development, especially in multi-electrode mapping and high-resolution mapping, because right now it's very difficult, for example, for a system to define for the system, for example, in this signal, what is the exact location for annotation. And this is exactly what we need in high-resolution mapping, the application of artificial intelligence for ablation and mapping. And it is very interesting, still in our classic mapping system, we have no artificial intelligence, but I find out that FDA has recently approved the first high-resolution mapping system. It's not a standard mapping system, but Ablation, the first mapping system, high-resolution mapping system, which used the annotation based on artificial intelligence. And I think that would be the next biggest step also for high-resolution mapping. So based on, for example, if we map an atrial tachycardia or ventricular tachycardia, and based on our preferences, what we are looking for, the system will generate a map based on artificial intelligence, deep neural networks, or machine learning whatsoever, depending on the system. And that would be also a very interesting step, and I hope that we see it in the near future. So we will still...
When you're talking about high resolution, could you comment on your choice of the HD grid and the system you've used compared with some other mapping approach?
So actually, I think the most important point is that there are different mapping system, and it's a matter of personal preferences. We can see, for example, I have another personal preferences for doing the ablation, but I use also this system. And I think the most important thing is how a doctor who performed the procedure feel comfortable with the system and know the system very well. Yes, please.
So based on now this map and the resources that you have, what is your favorite ablation strategy for this atrial tachycardia? I think everybody's now very excited to see what you are going to do and how you will terminate this terrible arrhythmia.
So it's a very good point, and I hope first it would be very interesting to see if it works. So as I saw the map, we can go again for propagation mapping, please. So as I see the propagation map, I said, okay, this is perimitral. And now we have different options for doing to interrupt this atrial tachycardia. Our preference, or my preference in this case, would be a septal line from mitral annulus and to the right superior pulmonary vein. And I think 2 regions with fragmented electrogram on the septum would be very interesting, and we have to include them in our ablation line. You saw the first point, and now as we go closer to the annulus, we can see that at this region we have low voltage and fragmented electrogram. So that would be our ablation line. And of course, still we didn't do entrainment mapping. And I really want to see if we can rely completely on this activation map. And if you want, we can also perform some entrainment mapping.
So why? I mean, the other option would certainly be a left atrial isthmus line. Why are you not choosing that one? What is the reason for that?
I think the reason is you are right. We can also go. Could you please go to the PA projection? Yes, you are right. We can, for example, do an ablation line, in this case from the mitral annulus to the left inferior pulmonary vein to do the mitral isthmus line. But the point is that in many cases, then not in the majority of the cases, but in a significant minority, up to 1/3 of the patient, then to finish the line and to complete the line of block, we have to go inside the coronary sinus and then to finish the ablation line and make the block complete. So in case of perimitral atrial flutter, we usually choose the septal line, and I think the possibility, it's not 100%, I know, but the possibility to terminate the tachycardia at this point during septal ablation, from my point of view, is maybe better, especially having in mind that we have some low voltage area and also fragmented electrogram on the septum.
So you
but
have
of course, it's
left to terminate.
Okay.
I
So
would start. If I were
she has 30 minutes. She has 30 minutes. Okay. So
Does the presence of
Can you
fractionated
show me?
signal determine where you're going to put your line? Like if you happen to find a lot of fractionated signal on the conventional mitral isthmus line, would you then do a conventional mitral isthmus line, or you always rather do a septal line?
in this case, actually, in this case, the mitral isthmus line was completely normal, no previous ablation. And I usually don't do it, but we have some older cases, actually, that we did, for example, posterior isthmus line ablations. And in these patients, when they get perimitral atrial tachycardia, then we complete the previous line of ablation in the posterior isthmus line. But otherwise, in most of the patients like this one, we go directly for the anterior line because the posterior line is completely normal. The posterior isthmus line is normal and no fractionated electrogram. Of course, for doing every ablation, we have different kind of options, and everyone can choose an option based on personal preferences. So now Angeliki will do the ablation, and Kastum will bitte the AP. We will go to the AP projection, and again.
Yep.
So now we will do the respiratory compensation.
Kannst du mir das Ablationsfenster auch geben?
Ja, ich mache das. Go.
It's a bit longer line. What is your experience of gaps, the frequency of gaps post-ablation?
AP, please.
Previously, it was very difficult to, without high power ablation, it was very difficult to get a complete line. Now, with a NAVAC system, we use the lesion size index with high power ablation. And also in CARTO, we use ablation index plus high power ablation. And in my experience, if we do the line point by point, and it's like the first pass PVI. And in most of the cases, it is a complete isolation of the line. It's also 80-90%. We will see it in this case. We will use the 50 watts, and then we go for a lesion size index of 5.5 at this location. And now,
Excuse me, on the right, mark the location of the HIS bundle before you do a septal line.
Pardon?
Sometimes when we're doing a septal line, we'll go over to the right atrium and mark the points where we're able to record the HIS bundle. Prior to doing the septal line, I find that if you go too low, you can cause AV block.
Yes, you're right, but based on our map and the fluoroscopy, I think we are not that too low. And you're right, if we want to go for a lower isthmus, lower septal line, we have to define the location of the HIS bundle. Either we can do it going to the right side and mark the HIS bundle, or we can go to the ventricle and return with the catheter on the septum to mark it on the left side. But on this typical location, which is high septum, usually we don't experience AV block. So yes, now we have to wait and see what happens during the catheter ablation.
How do you control for interlesion distance with this system?
So we don't have the measurement, but we only use, as you can see, the ablation point, and we put every ablation point. Yeah, it's difficult because we usually have to have 4 millimeter, not more than 5 millimeter distance between ablation lesions. But I think, as you can see here, the Angeliki put the ablation point very close to each other, and then in this way, I think we will have a continuous ablation line. But you are right, if it's possible to control for the distance, it would be much better to see that we are not higher than 4 to 5 millimeter. And in this case, for example, except for ablation points, we cannot see the distance between ablation catheter and the previous ablation point. But using the ablation points alone, I think would be enough, at least in this case. But when I do the ablation with the other system, then we can see easily the distance between the new catheter position and the last ablation point, and therefore we can easily see if we have in here a double potential, yeah. We can see very easily the distance. So I'm really excited to see what happens.
I think the tachycardia cycle length already got longer, doesn't it?
Yeah, I have to measure it. It looks that the tachycardia cycle length is longer.
Yeah.
So we have we started with 270, and now we are around 290 milliseconds. And this is exactly what we expect from macro-reentrant tachycardia, because we get gradual increase in the tachycardia cycle length until we get the complete block. Hopefully we will get it on the septum. If not, we will see.
Yeah, obviously the one thing to be aware of when you switch cycle length is that you had a double loop reentry and you've switched to the other loop.
This is possible, yes. Yeah, this is exactly the point, that if sometimes even without changing the tachycardia cycle length or with minimal change in the tachycardia cycle length, like in our patient, we may have a new circuit. So instead of doing the ablation again and again and again, in such cases we have to go for remapping. Maybe we have some new circuit, and then with a new ablation we can terminate the tachycardia. You are completely right.
So I'd just like to point out, while we watch with bated breath for what's going to happen here, that
yes,
there is a couple of audience poll questions.
Yes, please.
That perhaps we can put up so the audience can vote while we're watching to see what happens here.
Yes. Yeah, of course.
I can try. So I believe that unfortunately I can't quite see the poll, but I believe that the first question, these were questions submitted by the group in Leipzig, was which of the following LA maps is or are high resolution maps? And the choices are A, a map generated with an ablation catheter with 7,000 points. This appears to be a different question. So the question that you've put up, I believe, is patient with AF and PVI experiences AF recurrence 6 months after an ablation. In the second ablation, all PVs are isolated and the left atrial voltage map is normal. The next step during the catheter ablation should be manage modifiable risk factors, for example, hypertension, sleep apnea, and obesity, empiric posterior wall isolation, ablation of inducible non-PV triggers, all of the above, or just B and C. And I want you to know the entire time I was reading that, I was staring at the tachycardia to figure out if it was going to terminate. Looks like we're starting to get a pretty even distribution of answers, although empiric posterior wall isolation is growing. This reminds me of November in the United States, watching the election results here, constantly changing. Only I think in the election, if we had had the option in the United States to vote for none of the above, that would have been a very popular answer.
I can see somebody has asked what your irrigation rate is when you're ablating at high power.
is 30 milliliter. The catheter is Tacticat. Am I correct? Okay.
Yes.
The catheter is Tacticat, and during ablation with 50 watts, we have irrigation of 30 milliliter per minute.
In this situation
It-
where you obviously have
Yes.
completed the line visually, but you
Yes.
still do not
Yes.
have termination of the tachycardia, what is your, I mean, how long
Yes.
will you proceed, or what are your criteria to change strategy or continue ablating?
Yes, I think the next step at this time, Angeliki looks at the ablation line for possible gaps and for the signals. And after that, I will look at the map again with the propagation map, because lower at the septum, I saw some slow conduction zone. Maybe that's the important point. But I think before going for other ablations, the next step would be to remap the tachycardia even. We have the minimal change in the tachycardia cycle length. But still, I think that maybe remapping. Yes, please.
I think we unfairly pushed you off of your original plan of doing entrainment mapping, so you didn't have that advantage prior to this first ablation.
No, it's okay. I think the activation map was clear, and yes, usually we can do the entrainment map also, but if you want, we can do some entrainment mapping, for example, in this case.
Did you ever
It's always a risk
experience,
that you
did you ever experience cases where you had to block the anteroseptal line from the right atrium?
To ablate from the right atrium, actually, pure perimitral, no. But in some cases, no, from the right atrium, I didn't experience such a case to terminate the perimitral from the right side.
Before we move on to the second poll question for the audience, can you share with us your feeling about the answer to this first question?
Okay, which was the first question?
Excellent question. So the question was, you have a patient who has prior PVI for atrial fibrillation, has recurrent
okay.
Yeah.
Yes, there were different answers. So during ablation procedure, excuse me, during ablation procedure, modification of risk factors, it's very difficult. Therefore, all who answered modification of the risk factor, it's very important, but maybe before or after the ablation procedure. I think the second point is posterior wall isolation, which is one of the options. I would say everyone does not agree with it, but when we look at the posterior wall from the embryogenic origin, posterior wall actually has the same characteristics with the pulmonary vein regions. So, ja, hier auch, das würde ich das machen, ja. Mach das, ja.
Okay.
So the posterior wall has the same characteristics. So I think the posterior wall isolation as an not guided with voltage map or something like that is also a viable option. And the second point is ablation of non-PV triggers. Therefore, these two answers are correct. It means empiric isolation of the posterior wall. If we do it, it's not wrong. And also ablation of non-PV triggers of atrial fibrillation.
I think the problem with the sort of box lesions in the posterior wall is the higher risk for esophageal damage. So I think that kind of procedure would be very nice to be able to do once we get the pulsed field ablation in place.
Yes. Yes. Yes,
Karina,
you're
that's
right.
Absolutely correct. And in addition to that, there's a very recent publication from a Korean group looking into this topic, and they found that only if you can prove electrophysiologically that you have AF induction from the posterior wall, it's worth isolating it. So the empiric isolation did not provide any additional benefit. So I'm still really reluctant to ablate in this area extensively.
I agree that we have no randomized trials proving the benefit of posterior wall, neither of trigger ablation, but we have experience from the thoracoscopic AF ablation procedures in which box lesion is a routine, that the recurrences of AF is very low. So we have a very high success rate, even in long-standing AF ablation procedures in that case. So I do believe that the posterior wall do have a great impact if we can have a complete isolation.
Yeah, I think,
Which is a
as I
problem if
said,
you do endocardial lesions.
It's a matter of controversy, and that was exactly why I put this question to discuss about it. And the opinions are different. That was the reason why there are some ongoing trials looking for the effect of empiric isolation of posterior wall in redo procedures. And I think you're right. If we ablate on the posterior wall, the possibility of having esophageal lesion, that is something that we have to think about it. But I think first with the pulse field ablation, then we don't have such a problems in the future. And even with high power short duration, I think the problem is much less than a standard ablation with 20 or 35 watts or 25 watts for a longer duration. Usually, personally, when I do posterior wall isolation with high power short duration, I do an esophagoscopy the day after the procedure to check for the thermal lesions in the esophagus. But this would be for the coming months or years before we have the pulse field ablation available.
What power do you use on the posterior wall when you do high power? Is it the same as anterior or still less?
Still is 50 watts, but for example, with the Carto system, then I use an ablation index around 380 and with lesion size index, with the lesion size index 4. On the roof, we use 5, and on the other regions, we use 5.5 lesion size index. With Carto, then we use 380 on the posterior wall and 500 to 550 in other regions.
May I bring up one more answer to your question? So
yes.
What does the faculty think about deferring catheter ablation in such a case? Because you don't have any voltage abnormalities, you have isolated PVs. Why don't we just prescribe flecainide or whatever antiarrhythmic drug and leave this patient alone before mutilating his left atrium?
So this would be...
I guess you're already inside the left atrium, having done a map, and I think the temptation is probably too great rather than to just leave it be and stop the procedure at that point without any ablation at all.
Mm-hmm.
Yeah, well, you did this in a good intention. You thought maybe the PVs are not isolated, and now you have more information, and you don't see any sources of atrial fibrillation. Why not stabilizing him with the drug?
Okay.
Yes, I think that would be also one of the options. But I thought, as we decided to go for ablation, so usually we in such cases we have, in most of them, not all of them, in most of them we have some failed antiarrhythmic. We tried an antiarrhythmic and it didn't work. So that's the reason that we went for ablation. I think that even in patients, in patients with isolated pulmonary veins after previous PV isolation and atrial fibrillation, then there should be something. Maybe the most probably extra pulmonary vein triggers, and in my experience, many of them has a sleep apnea syndrome, undiagnosed. And I think this is one of the important thing to, of course, before doing the ablation procedure, so we have to modify the risk factors. For example, last week we had a female patient. A woman came with atrial fibrillation, and she said she already lost 20 kilos, and she's planning to lose an additional 20 kilogram. And I said, I congratulate you, and I would like to defer catheter ablation because maybe after losing the second 20 kilogram, maybe he remains stable, or even she remains stable in sinus rhythm, or maybe she will experience a better ablation outcome when she lose at least 40 kilogram of her body weight. So I think this is very important to modify the risk factors, especially a sleep apnea syndrome, hypertension, diabetes, and everything, and overweight. But you're right. But during the procedure, to finish the procedure and say we give the patient antiarrhythmics and to see what happens, and if the antiarrhythmics fail, we do the catheter ablation. But during the second catheter ablation, we will still have the same problem with normal voltage map and isolated pulmonary veins.
So I think Dr. Schmidt makes an important point, which is that, as we all know, AF ablation, particularly for persistent AF patients, is not as effective as we'd like it to be, which leaves us very often in the position of wishing that we could do something more to fix our patients. And the onus is on us to make sure that there's a good justification for delivering whatever lesion set we're going to deliver in a given patient. And unfortunately, we don't really have the greatest mapping tools to answer the question, what's a rational ablation strategy? But before we run out of time, I'd like to address the second polling question that was posed to the audience. The question was, which of the following LA maps are high-resolution maps? And the choices were a 7,000-point map generated with the ablation catheter, a 7,000-point map generated with the CS catheter, or a map generated with the HD grid with 7,000 points, or all of the above. And I'm curious what your answer to that question would be, Dr. Arya.
Yes, my answer would be C, because there is a difference between high resolution and high density map. All of these maps, for example, all these maps have 7,000 points. It means they are all high density maps. But more points doesn't mean that we have a high resolution map. To have a high resolution map, we need very small electrodes. And this is what we usually don't have with the ablation catheter or a conventional, or a conventional CS catheter. Therefore, all these maps are high density maps, but from my point of view, only those we generated with very small electrodes are actually high resolution maps. It means that in this case, it's the HD grid map is a high resolution one. So as we talked during the procedure, you saw that we have some differences in cycle length, and then the activation pattern changed, and now we have somehow different activation pattern and cycle length. And I think in this case, the next step would be to go for a new activation map to continue the procedure. And I would like to know your opinion about the next step in this procedure.
Well, I, for one, completely agree that that repeat mapping is important under this circumstance before just continuing to empirically ablate. What
It
about the
would
rest
be
of the
nice
panel?
to do some. It would be nice to do some entrainment mapping, maybe at this stage. That would give us a bit more information.
Okay, okay, that would be. So at this point, for example, I can try to entrain from coronary sinus, and then when we put the catheter again inside the left atrium, we can do the end. So
There is always the
first
risk
I
of
have.
terminating the tachycardia, and then you cannot start it again. So
Yes,
Yeah.
yes, that's always the problem with entrainment.
yeah.
We
And
may
to add to the
terminate or
pressure,
change.
you have 2 minutes left.
Okay, so Angeliki, you have 2 minutes.
Okay. Okay. Yep.
So we will continue the map, and I think this is very important to sometimes it's easy, sometimes it's more difficult, but it's very important if we want to have on the long-term basis a good successful reablation. We have to eliminate this regular atrial tachycardia. And the most important thing, even a minor change in the cycle length or the minor change in the activation pattern means that we might have a new tachycardia, and we have to go for a new map and to understand the tachycardia and ablate it. Of course, the next possibility would be to do
And it's roof dependent.
ablation until we terminate the tachycardia, but in this case that doesn't make sense, because then we will destroy the left atrium completely. And of course, with the strategy which I called it no atrium, no fibrillation, then we can ablate everything, but it doesn't make sense, I think. And we have to
Yeah.
map the tachycardia and see what is the new tachycardia that we have, and then try to ablate it.
Well, our session is going to come to an end, but before
Okay.
we do, I'd like very much to thank you for welcoming us into your lab to watch this case, and the commentary has been very useful. I'd like to thank the panel for their questions. Your insights have been helpful, and hopefully we can get the answer later on in the meeting about what happened with the case.
Oh, I would like also to thank you for your good comments, and that was my honor to be with you during this session. And we will inform you about how we finish this patient.
Excellent. Thank you very much.
Thank you, Art.
Okay.
Thanks.
Thank
you.
you. Thank
Thanks,
you.
Peter.
Thank you.
Have a nice evening.
Bye, everybody.